And we can use ISQ readings as a management or communication tool. I'm obviously in private practice, and one of the things I do is I send back a letter every time I treat a patient. And in that letter now I include a listing of the ISQ readings for that particular patient. And I've educated my practice, the people that refer to my practice, as to what these mean and what they can sort of expect from the number. If we look at another case, however, and this is tooth number 13, and we can see here that at the placement we had very good readings, 71, 71, 68, and 69, but clearly at stage 2, which is 6 months later, 46, 48, 46, 48. Now, if you tapped on an implant, if you twisted that implant, it still felt solid, but clearly this implant's failing. And it took very little to remove this implant and back it out. And so we saved this patient from going back to the restorative dentist and actually having a disaster with a failed crown on a failing implant. So in closing, what are some takeaway thoughts that we can have with this device? I've integrated it into my practice so it's a completely, totally important part of the practice. Every patient gets Osstell readings in all 4 quadrants. And we can see that it's an excellent and it's non-invasive device for measurement of implant stability. And I emphasize non-invasive because a lot of my colleagues in Portland, Oregon use the reverse torque technique where they literally try to unscrew the implant before they send the patient back to the restorative dentist. It allows you to be certain that the smart peg, it's important for good readings to make sure that smart peg is securely placed into the implant. You'll get false negative readings if that is not totally engaged in the implant. Record all 4 quadrants, I think, to get a correct understanding of what's really going on with that implant. Buccolingual versus mesial distal. You may be able to tell, at least subjectively, where the weak point on the implant is. For instance, these anterior maxillary implants that you're early loading, you certainly don't want these implants in a protrusive load because of the fact that you'll see if you start doing a lot of this that the weak point is buccal and often palatal. So it may suggest where the weak point is. It's an excellent way to communicate with your colleagues, your restorative colleagues. Or if you're a restorative colleague, it's an excellent way for you to discuss things with your surgeon. And I think it helps me improve my results. It makes me understand where I can do things more aggressively versus less aggressively. And finally, I think it eliminates sending a failed implant back to a clinician and going through the process of then having to redo the entire process, which, like Danny said, is a matter, in my practice, we redo everything at no charge. So the less we can do of that, the better off we're going to be. So I want to thank you, and I want to thank Lars and Osstell for this kind invitation to come to Scotland. I hope that you've gotten an opportunity to see just how I do this in a private clinical practice setting. Thank you very much.